can't see you guys. But if there's any questions at all, literally just shout because I probably won't be able to read the chat. So, okay. So I'm gonna be talking about cardiac output today, which is really essential. Like if you get this concept, like cardiology would be so easy. Okay, so cardiac output. So firstly, let's start by defining what cardiac output actually is. So we have this equation, which I think I showed you guys last week as well, when I was talking about the renin-angiotensin-aldosterone system. I showed you this exact equation, which was cardiac output is the product of heart rate and stroke volume. So heart rate, so let's just write that down again. So cardiac output, sorry, my handwriting is terrible. So cardiac output is the product of heart rate and stroke volume. So heart rate is the number of beats per minute, correct? So it's the number of heartbeats per minute. And stroke volume is essentially the volume of blood that gets ejected by the heart, more specifically by the ventricles, in one heartbeat. So again, stroke volume is the volume of blood that gets ejected out of the ventricle in one beat. So volume we measure in milliliters or liters if you want, but let's just put milliliters. And I told you it's per beat. So given this equation, can you guys tell me what the unit is for cardiac output? Yeah, correct. So it's gonna be milliliters per minute because the beat, they cancel out. So cardiac output is gonna be mils per minute. So the definition of cardiac output is essentially this. It's the volume of blood pumped by the heart in 1 minute. So it's the volume of blood that gets ejected from both ventricles in 1 minute. So that is the definition of cardiac output. So the normal cardiac output, so this is the question, what's normal cardiac output? So the normal is approximately 5,000 milliliters per minute or 5 liters per minute. So where does this number actually come from? So let's use this equation as an example. So I'm just gonna write it below. So heart rate, typically a heart rate of an adult is 60 to 100, correct? So let's use 70 as our example. So 70 beats per minute. And typically our stroke volume is around 70 mils per beat. So our ventricles eject approximately 70 milliliters of blood in one heartbeat. So it's going to be 70 times 70, which is 4,900 milliliters per minute. So that's approximately 5,000 mils per minute or 5 liters per minute. So that is the approximate normal cardiac output in an adult. All right, so I hope that makes sense as to why we get this number. So what happens then, using this equation, just think about this logically, what would happen if we increase our heart rate? What would happen to our cardiac output if we increase our heart rate?
It will increase.
Sorry?
It will increase.
Yes, it will increase because from this equation, heart rate is directly proportional to cardiac output. So if we increase our heart rate, we will increase our cardiac output. So the third question, what will happen to cardiac output if we increase our stroke volume?
Increase.
It will increase as well because stroke volume is directly proportional to cardiac output. So let's say I decrease my stroke volume. What will happen to cardiac output?
Increase.
If I decrease my stroke volume, what will happen to my cardiac output? Will it increase or decrease? It will
Decrease.
Yes, correct. It will decrease because they are proportionally, they are directly proportional. So whatever happens to heart rate is what's going to happen to cardiac output, and whatever happens to stroke volume is going to be reflected in cardiac output. So this equation is essential, and even to this day, we still use this. So when you progress in your medical studies, you shouldn't forget this equation. Okay, so I hope this slide is clear. Do you have any questions about this slide? Should I move on? Okay. So stroke volume. So again, just to remind you, cardiac output is stroke volume times heart rate, right? So So now let's talk about stroke volume. So what is stroke volume? Well, I said it's the volume of blood that gets pumped from each ventricle in one beat. So we actually have a formula as well to calculate this. So stroke volume is end diastolic volume minus end systolic volume. So now I'm introducing more terminologies here. I'll just clear this slide. So, right. So stroke volume is end diastolic volume minus end systolic volume. So let's say this is the heart. So this is the right atrium, the right ventricle, the left atrium, and the left ventricle. So guys, remind me of the cardiac cycle. We have systole and diastole, correct? And what is diastole?
Relaxation of heart.
Yes, it's the relaxation of the heart. More specifically, well, we could say ventricular relaxation. And what is systole? The opposite, which is contraction. So in diastole, the heart fills with blood. So we have blood coming from our inferior and superior vena cava draining into the right side of the heart. So in diastole, we get blood coming back to the right side of the heart from the inferior and superior vena cava. So it starts filling. And simultaneously, at the same time, we get blood coming from the pulmonary veins draining into the left side of the heart. So that gets filled as well. This happens during diastole when we have ventricular or just cardiac filling. And towards the end of diastole, when the ventricles get, maximally filled with blood, that's called end diastolic volume. So end diastolic volume is just the volume of blood, like towards the end of diastole, like when it's maximally full. So that volume is typically 130 milliliters. Okay? So at the end of diastole, obviously we finish the filling of the blood, it's time for the heart to contract. And this is systole. So the right side of the heart, when it contracts, where does it pump blood to? Where does it go?
Aorta.
Sorry?
Aorta.
The right
Systemic circulation. The right side, pulmonary artery.
Yeah, the pulmonary artery, the pulmonary circulation. Okay? So it goes out via the pulmonary artery into the lungs, the pulmonary circulation. And the left side of the heart, where does it pump blood out to?
Aorta.
The aorta, the systemic circulation. So in systole, when during that period of ventricular contraction, not all the blood inside the ventricles get pumped out. Some blood remains in the ventricle after systole, and that's what we call end systolic volume. That's ESV. So typically, we have 60 mils of blood that remains after systole. So to calculate stroke volume, we said end diastolic volume, the volume of blood that's in the heart after ventricular filling or diastole is 130. This is in milliliters. And end systolic volume, the amount of blood that gets left behind the ventricles after contraction is 60. So what is the stroke volume? Yeah, 70. So 70 milliliters, okay? And this is normal for an adult. So again, stroke volume is the amount of blood that gets pumped out per beat, per heartbeat. And that's just basically taking away end systolic volume from end diastolic volume. So I hope you understand that. And do you have any questions about that, where I got those numbers from? Is it okay to get it? Okay. Right. So we have three factors that affects our stroke volume. So it's the three factors are preload, contractility, and afterload. And we're going to be discussing each of these factors in the next few slides. So again, we're discussing stroke volume because stroke volume directly affects our cardiac output. So that's why we're discussing stroke volume. And there's three factors that affects stroke volume: preload, contractility, and afterload. So preload. Preload basically, it just refers to the stretch of the ventricles during that diastolic period. So I put here, it's the stretch that the blood places on the walls of the ventricles at the end of diastolic filling. So remember this, where is it? The diagram that I drew. So this, when we get to the end of diastole, when we get to that end of ventricular filling phase, the heart gets maximally stretched, okay, because it gets filled with blood. So it's like maximally stretched. And that stretch, that is our preload. So preload is basically just the stretch of the ventricles during that ventricular filling phase, during that diastole, right before systole, right before we contract. Do you get that definition, guys?
Yep.
Okay. Preload just refers to the stretch of the ventricles at the end of the diastolic filling period, literally just before systole. So, how do we increase preload? So again, going back to this squared heart, how are we going to increase this filling? It's kind of obvious. We basically just try increase the amount of blood that's going into the ventricles, right? And literally, that's what we call venous return. So if we increase our venous return, if we increase VR, venous return, we're going to increase our preload. If we're going to increase the volume of blood that goes back to the heart during diastolic filling, then we're going to increase our preload. So how exactly can we increase our venous return? So there's so many ways, but I wrote three here that's like quite easy to understand. So we can increase venous return by exercising. So by running, exercising, walking, and this is actually called muscular milking activity. I did another class and I mentioned this and they thought I was joking. This is legit, guys. Like, I'm not making this up. So muscular milking activity is basically, like when you're walking and when you're exercising, we have veins in our legs. Like, we have deep veins, the femoral vein, the popliteal vein, anterior tibial vein, posterior tibial vein, all of these veins. So I'll draw that. So this is like a vein, and a vein, they have valves, right, to prevent backflow and to aid the movement of blood towards the right side of the heart, back to the heart. And around those veins, we have skeletal muscles. So these are, just imagine they're skeletal muscles. I'm terrible at drawing. So when we move, so when we walk, like imagine this is like your calf muscle, or when you're doing like calf raises at the gym. What happens is when they contract, when you move, when you do something, they help propel the blood back up to the heart. So they contract, and when they contract, they help propagate blood back to the right side of the heart. Okay? So veins, the thing is, veins are a really low pressure system, and they have to work against gravity. So the only kind of pump that's helping them pump blood back to the heart are our skeletal muscles surrounding the veins. So if you increase your muscular milking activity by running, walking, gymming, squatting, calf raises, you're contracting those skeletal muscles around the vein, and you help propel blood back to the right side of the heart. And this increases your venous return, which will increase your preload. Okay? The second one that can increase venous return is inspiration. So when we inspire, when we inhale, what happens is that our diaphragm contracts. It kind of pulls the chest kind of down, and then the intercostal muscles, they like raise the ribs, right? So in total, what happens is that we increase the intrathoracic pressure. We have more volume. We increase the intrathoracic volume. We have more volume in the chest cavity. So when we have more volume in the chest cavity, volume and pressure are inversely related. So if we increase our volume in the thoracic cavity, we're going to decrease the pressure in the intrathoracic cavity. And this decrease in pressure acts kind of like a vacuum. So it kind of like tries to suck blood back into the right side of the heart. So that's what happens during inspiration. And this is called the respiratory pump. So just to say that again, when we inspire, when we take a deep breath, our lungs, they expand, so there's more volume in the thoracic cavity, and that leads to a decrease in pressure, in the thoracic pressure. When we decrease our intrathoracic pressure, that creates that vacuum effect that kind of draws blood back into the right side of the heart. So that increases your venous return, and that increases your preload, okay? And the third one is vena motor tone or venoconstriction. So vena refers to the veins, and constriction is the constriction of the smooth muscles in the vessels. So imagine, like, when you're squeezing like a tube of toothpaste. So when you're squeezing, you're trying to like squeeze the fluid inside and it goes out. So similarly with the veins, if you venoconstrict those veins, the inferior superior vena cava and the smaller veins, what you do is you're trying to propel blood back to the right side of the heart again. You're trying to squeeze those veins for blood to go back into the right side of the heart. So this increases venous return, and this is going to increase preload as well. Is that clear, guys, as to how we can increase our preload?
Yeah, that's fine.
Yeah? Okay. So now what decreases preload? There's quite a lot of stuff here. I'll try to explain them. So what decreases preload if we decrease our filling time? So recall that I told you that the ventricles, they get filled during diastole, right? And do you guys know the typical length of a cardiac cycle? What is the typical length of a cardiac cycle?
Isn't it 0.8 seconds or something?
Yes. So it's, sorry, I'm writing that. So a typical length of a cardiac cycle is 0.8 seconds. And it's divided in diastole and systole. And diastole typically is longer, the filling phase. It's usually 0.5 seconds. And the systole is usually 0.3 seconds. So did someone have a question? Someone raised their hand. No? Okay. So a typical cardiac cycle made up of systole and diastole. Diastole is longer, typically. It's 0.5 seconds. And systole is 0.3 seconds. So the heart gets filled during diastole. If we decrease the filling time, if we shorten the period that we're in diastole, then we're going to decrease the amount of volume that gets into the ventricles, right? So it's kind of intuitive. If we decrease diastole, we're going to decrease the volume of blood that we can fill the ventricles with. So this can happen if we increase our heart rate. So when we increase our heart rate, systole is constant. Systole is always going to be 0.3 seconds. Systole, like the ventricles are going to take the same amount of time to contract, regardless if your heartbeat is like 50 beats per minute or 100 beats per minute. The only thing that changes is the time it spends during diastole. So if diastole gets shorter, if you increase your heart rate, then it's going to decrease the filling time. So you're not going to be able to have as much volume of blood in the ventricles during diastole. So if you decrease your filling time, you're going to decrease your venous return, and you're going to decrease your preload. Okay? So the second one, so we've covered that. The second one is previous MI. So we all know what an MI is, right? It's myocardial infarction. And in infarction, you have scar tissue formation. So when you have scar tissue, because the tissues just died, it was ischemic for a long time and the ischemia hasn't been reversed, so they die and they form scar tissue. So imagine here for a second that on my left ventricle here, I have like a massive MI, which means just like death of the tissue, scar tissue. And scar tissue is not very pliable, it's not very stretchable, it's not very distensible. So if we have like a previous MI, that scar tissue isn't going to want to stretch. So if that ventricle isn't stretching to its full capacity because of that scar tissue, then it's not going to be able to fill with enough blood, or fill with as much blood. So if we have a previous MI, loads of scar tissues around, we're going to decrease venous return because the ventricle itself really can't stretch out that much. So we're going to decrease our preload. Okay? If you have any questions, just shout, guys, because I'm trying to go through these. Does that make sense? How an MI can lead to decreased preload?
Can you repeat, please?
Sorry?
Can you repeat the explanation?
So an MI, a myocardial infarction, infarction means like death of the tissue in the myocardium. So when those cells die, they form a scar tissue. So the normal contractile myocardium gets replaced by a scar tissue. In scar tissue, they are not as stretchable, as distensible, as pliable as a normal myocardial tissue. So when we have a ventricle that has like infarcted tissue, like tissue that are dead, tissue that's scarred, it's not going to be able to stretch out as much. So when it comes to the filling of the ventricles, it's just going to be stiff. It's not going to like want to stretch out. It's just going to be like that. Okay? So sorry?
Okay.
Yeah, so that's what happens if we have like a previous myocardial infarction. It doesn't happen to the whole ventricle. It just happens in like parts of the ventricle with the dead tissue. But obviously, if you have a massive MI, it might lead to the point where it's not very distensible. So, you're not going to fill it with as much blood. Okay. So the next one is hypovolemia. This is fairly intuitive. If you don't have so much blood volume circulating around the body, then you're not going to have a lot of blood going back to the right side of the heart. Okay, so hypovolemia is gonna decrease venous return just because you don't have much blood to circulate around in the first place. So the next one is stenotic valves, so mitral and tricuspid valves. Okay, I'm gonna try and make this as easy as possible to understand. So this can decrease preload. Remember that I told you that the ventricular filling happens in diastole, correct? We know that much. What I didn't tell you is that during diastole, so again, I'm going to draw my heart, right atrium, right ventricle, left atrium, left ventricle. During diastole, ventricular filling, the heart gets filled with blood. 80% of that filling happens passively. So 80% of the end diastolic volume, of the volume that fills the ventricle during diastole, 80% of that blood is passively getting into that heart. So we don't have any other intervention. It just fills with blood. And that is like 80% of the end diastolic volume. So the ventricles gets filled with blood during diastole, and 80% of that is just passive. Nothing is doing anything here. Like the valves are not doing anything. The atria are not doing anything. The ventricles are just taking in all of this blood. So that's what happens for 80% of the volume. The last 20% is because of the atrial kick. So the last 20% of that diastolic filling is because the atria is pumping its blood contents into the ventricles. Okay? So when we have mitral and tricuspid valve stenosis, so the mitral valve is in the left side of the heart, and the tricuspid is on the right side of the heart. If we have stenotic valves, which means they are narrow and they're basically really hard to open. So they're very rigid, narrow. They just don't want to open at all. If we have stenotic valves, then it's going to be harder for that atrial kick to happen. It's going to be more difficult for the atria to contract against that stenotic valve. So it's going to be harder for us to get that extra 20% of blood into the left ventricle and the right ventricle before systole, before ventricular systole. So if we don't have that, 20% for the diastolic volume, then we're not going to be able to, it's going to decrease our preload. It's going to decrease that stretch just prior to systole. Does that make sense? Do you guys get that?
Yeah, that's fine.
Sure? Yeah? Okay. So The next one is restrictive cardiomyopathies. So in restrictive cardiomyopathies, essentially, this can be caused by different things. So amyloidosis, this is the buildup of a protein called amylin in the myocardium. Sarcoidosis, buildup of tiny immune cells that form granulomas inside the myocardium. Hemochromatosis, buildup of iron in the myocardium. And radiation fibrosis is just fibrosis because of radiation therapy. So in patients with lung cancer, they get radiotherapy for their lung cancer. And because the heart is in the vicinity of the lung, when they get radiotherapy, their myocardium gets damaged by that radiation, causing radiation fibrosis. So in restrictive cardiomyopathies, we have these depositions of whatever material like amylin or iron, which makes the heart very like non-stretchable. So it's basically these deposits, these infiltrations of random stuff in the heart makes the heart not want to expand so much. So if it doesn't want to expand so much, then it's not going to feel so much. So we're going to decrease our preload as well if we have these things going on. If we have amyloidosis, hemochromatosis, radiation fibrosis is similar to the mechanism of an MI. If we have fibrosis because of radiation, we have scar tissue. Scar tissue doesn't stretch. So if we have fibrosis or scarring of like the myocardium, it's not going to stretch out so much. So it's not going to feel so much. We're going to decrease the preload. Okay? The next one is hypertrophic cardiomyopathy. So if you look at this diagram here, hypertrophic cardiomyopathy is essentially the thickening of the septum. Can you see the septum? It's so big. And also the thickening of the left ventricular wall. So this is what happens in hypertrophic cardiomyopathy. For whatever reason, the septum just decides to bow out and grow into the left ventricular chamber space. And the left ventricular wall here is very thick as well. So this, can you see the diameter now of the left ventricle? It's much smaller than this normal heart here. So if we have a smaller diameter, it's not going to fill with so much blood. So again, this is going to decrease the preload. Okay? The last one is ventricular hypertrophy. So ventricular hypertrophy can happen because of hypertension or aortic stenosis. It's the same principle. If the ventricles need to get bigger because they need to overcome like a higher resistance. So let's take systemic hypertension, for example. If we have high pressure in the arterial system, the left ventricle has to work hard to push blood against that high pressure system. So what it does to kind of to accommodate for this increase in pressure in the systemic circulation, it becomes bigger. So from this, can you see this? This normal heart, because it now needs to accommodate a higher pressure in the systemic circulation, it undergoes concentric hypertrophy. So the walls get bigger. It's like the left ventricle is on steroids. So it gets thicker, the left ventricular wall, and the lumen and the diameter is now much smaller. So it's not going to fill with so much blood anymore compared to the normal ventricle. So that's why we're going to decrease the preload, because it's just not going to, it doesn't have much space in there to fill with blood in the first place. Okay? So do you guys get this slide? Any questions before we move on to the next one? Guys? Okay. I hope this is clear, what decreases preload. So we have this law related to preload. So it's called Frank-Starling law. So the more you structure the heart, the greater the force of contraction. So this is just the relationship between preload and stroke volume. So I told you preload refers to the structure of the heart, right? And when there's more stretch, there's increased force of contraction. So if there's an increase in end diastolic volume, that's going to increase the stretch, that's going to increase our preload. And if we have a higher preload, we're going to increase our stroke volume. So this is Frank-Starling law. Okay, basically the more stretch that the ventricles get during that ventricular filling, the higher the force of contraction, and therefore the higher the stroke volume will be. So now, when we have an increase in stroke volume, what's going to happen to our cardiac output?
Increase.
Increase, yes. So if there's an increase in stroke volume, there's also an increase in cardiac output. So if there's increase in stretch of the heart, which is preload, there's an increase in stroke volume, there's an increase in cardiac output. So this is basically what Starling law is trying to state. Okay. The next factor that affects stroke volume is contractility. This is very easy. So we have agents that can affect the contractility of the heart. So we call these positive inotropes and negative inotropes. So inotrope is just something that can affect the contractility of the myocardium. So positive inotropes, they basically make the myocardium more contractile. So they increase the force of contraction. And on the other hand, negative inotropes are just agents that decrease the force of contraction. Right? So positive inotropes, they can be epinephrine or norepinephrine. So if you activate your sympathetic nervous system, you increase the release of epinephrine or norepinephrine, and they bind to beta-1 adrenergic receptors, and they trigger cascade of reaction. And ultimately, what they do is they increase the calcium inside a myocardial cell. And an increase in calcium means increase in the contractile force, because calcium is linked to the contraction of the myocardium, right? So if you increase calcium in the cell, you increase the force of contraction. So positive inotropes, epinephrine and norepinephrine. The other ones would be hormones. So we have T3 and T4. These are your thyroid hormones, and they increase the force of contraction because they increase the expression of beta-1 adrenergic receptors. And I told you that beta-1 adrenergic receptors, these receptors are where epinephrine and norepinephrine bind to. So if we have more of these receptors around, then this is going to increase the chance of the epinephrine and norepinephrine binding to these kind of receptors and generating that contractile force of the heart. Okay. The next one can be drugs. So catecholamines. Catecholamines are essentially just norepinephrine and epinephrine. So if you give norepinephrine or epinephrine to someone, it's going to increase the calcium inside your cell, and it's going to increase the contractility of the heart. Caffeine, digitalis, dopamine, atropine, dobutamine. So all of these drugs, all they do is they increase calcium inside the cell. They work via different mechanisms. They have different mechanisms of action, but ultimately the goal that they're trying to achieve is increase calcium inside the cell. Because if you have more calcium inside the cell, you're going to increase the contractility of the heart. And obviously, ions like calcium. Okay, so just remember positive inotropes, epinephrine, norepinephrine, T3, T4, and calcium. That's essentially it. The negative inotropes, on the other hand, so these are agents, chemicals, things that decrease the contractility of the heart. So we have drugs like beta blockers, calcium channel blockers. Calcium channel blockers block calcium, so we're going to decrease calcium inside the cell, and that's going to decrease contractility. Beta blockers kind of act similarly, but to a less extent. Ions, obviously, if we don't have much calcium going around, if we have hypocalcemia, then that's going to be, negatively affect the contractility of the heart. If you have dilated cardiomyopathies, so, okay, can you see this heart here? This is a normal heart. Pay attention to the size of the chamber and the thickness of the ventricular wall. So in a dilated cardiomyopathy, we have dilated heart. So this heart is much bigger than this one. And the walls of this heart is a lot thinner than this one. So you can't see where I'm pointing, but the heart on the right side is much bigger, and the ventricular wall is much thinner. So if the ventricular wall is thin, it's not going to be as powerful, it's not going to be as strong, it's not going to be as contractile as the one on the left side, where we have a normal thickness myocardium. So this happens in things like, this is dilated cardiomyopathy. Okay, so this happens when we have leaky heart valves or valvular regurgitation. So for instance, valvular regurgitation means that the valves, they are not closing properly. So the valves should close properly to prevent backflow of the blood. So for instance, we have aortic regurgitation. So in aortic regurgitation, the aortic valve, which is here, just before the aorta, they don't close properly, they don't shut properly. So what happens is when the left ventricle contracts, instead of all the blood just going to the aorta, a lot of the blood actually comes back into the left ventricle. And over time, what that's going to do is it's going to stretch out the myocardium because it's trying to accommodate for that increase in volume that's going back into the left ventricle. The left ventricle is just used to pumping blood out. It's not used to receiving all of these blood coming back from the aorta. So it's gonna accommodate by dilating. So if we have dilation of the chamber space, the walls are gonna be thinner. So they're not gonna be as contractile. They're not gonna be as powerful. So this is gonna reduce the contractility of the heart. So this happens in heart failure, congestive heart failure, that is, and post-MI. Also, post-MI, because scar tissue, I told you, it doesn't stretch out so well, right? That's why we will have decreased preload if we have a patient who had myocardial infarction in the past. But at the same time, scar tissue isn't contractile as well. Scar tissue doesn't contract too. So if scar tissue doesn't contract, then that bit of tissue is not going to contribute towards the contractile force of the myocardium. So if someone had an MI, that scar tissue is not going to help the heart contract. So the contractility would be less. Okay? So I hope this makes sense. Do you guys have questions about the slide? No? Okay. The last one is afterload. So afterload refers to the pressure that the left ventricle needs to overcome to push blood out of the heart. Okay? So things that can increase afterload. So, okay, I was going to draw the heart again, but it doesn't matter. Okay. Afterload refers to the pressure or the resistance that the ventricles need to overcome to push blood out. Remember that the right ventricle pushes blood to the pulmonary circulation, right? If we have a high pulmonary pressure, in the case of pulmonary hypertension, that will increase our afterload. Similarly, if we have high systemic arterial pressure, which means we have systemic hypertension, the left ventricle needs to overcome that increase in pressure to be able to pump blood out. So things that can increase your afterload, we already talked about systemic hypertension. And this makes it more difficult for the left ventricle to pump blood out of the heart. Pulmonary hypertension is going to make it difficult for the right ventricle to pump blood out. And other things like atherosclerosis, artery stenosis. So in atherosclerosis, the vessel, they have these plaques, right? And because of this, look, it narrows the lumen so much. And I told you if the volume is decreased, the pressure is gonna increase. So here we have a narrower lumen. We've decreased the volume of this vessel. So that means there's gonna be an increased pressure in this vessel. So if this happens in our systemic circulation, we're gonna increase the pressure in the systemic circulation. And that's going to increase your afterload. Okay? Aortic stenosis, it's just the stenosis of the aortic valve. Again, it's going to make it difficult for the left ventricle to pump blood to the systemic circulation if this aortic valve is stenotic, if it's narrow, if it doesn't want to open. The last one that can increase our afterload is vasoconstrictors. So remember last week I talked about renin and angiotensin II. So angiotensin II is a very powerful vasoconstrictor. So if we vasoconstrict our arteries, it's gonna increase our afterload because vasoconstriction, we're decreasing the volume inside the vessel, and when we decrease the volume inside the vessel, we increase the pressure, right? So vasoconstrictors, hypertension, and atherosclerosis are the main ones that can increase our afterload. Things that can decrease our afterload are vasodilators. So they do the opposite. When they dilate the vessels, if they dilate the arteries, there's going to be less pressure that the left ventricle needs to overcome. So it's going to be much easier to push blood out from the left ventricle to the systemic circulation. So, yes, David?
So the blood vessels have to widen then?
So if the blood vessels widen, that's going to decrease your afterload. Because again,
that's what I was going to say. Does it have to widen in order to increase the afterload?
yes, it has to widen. Because, like I said, if you increase the volume in whatever given space, like in the blood vessel or in the heart, volume and pressure, they have inverse relationships. So every time you dilate a vessel, the pressure inside that vessel, so it's gonna, if you dilate it, the volume gets bigger, so the pressure gets smaller. So if you have if you have less pressure inside the arteries and the veins, we're gonna have a decrease in afterload. Okay? So dilating the vessels mean that we're gonna have decrease in afterload, because afterload is the resistance that you need to overcome to push blood out. And one way to eliminate that sort of resistance is to dilate the vessels. So we can use drugs like nitroglycerin, hydralazine, nitrates like isosorbide nitrate. These are blood pressure medications actually, and ACE inhibitors, which we talked about last week. So just to summarize factors affecting your stroke volume, you have preload, contractility, and afterload. Now, what will happen if I increase my preload? What's going to happen to stroke volume?
It will increase.
It will increase. Great. If I increase the contractility of my myocardium, what's going to happen to my stroke volume? Yes, if my heart is more contractile, it's going to increase my stroke volume. If I increase my afterload, what's going to happen to my stroke volume?
The stroke volume will decrease.
Will decrease. Perfect. You guys get it. So preload and contractility, they are directly proportional to stroke volume. But afterload is inversely proportional to stroke volume. So if I increase my preload, I'm going to increase stroke volume. If I increase contractility, I'm going to increase stroke volume. But if I increase my afterload, it's going to decrease my stroke volume. Okay? The last one is heart rate. So remember, again, cardiac output is stroke volume times heart rate. And we've kind of butchered stroke volume. We've covered literally all the factors that can affect your stroke volume, including preload, contractility, and afterload. Now let's briefly discuss heart rate. This is very intuitive, guys. What is the normal heart rate for adults?
60 to 100.
60 to 100. What is bradycardia then?
Slow heart rate.
How slow?
Less than 60.
Less than 60. What is tachycardia?
High heart rate.
How high?
More than 100.
More than 100. What sets the heart rate? What sets the pace of the heart? Why is it 60 to 100? Why is it not 150 to 300? What sets this rate? What is the pacemaker of the heart, the natural pacemaker of the heart? Sorry?
You mean the SA node?
Yes, the sinoatrial node. So that sets this rate of 60 to 100, because the SA node fires about 60 to 100 times per minute. That's why we have this rate of 60 to 100. It sets the pace of the heart. And do you know where the SA node is located? This is SA node right here. And do you know where SA node is located?
Right atrium.
Right atrium. So what can influence our heart rate? Because this is essentially what we're going to talk about. But I think you guys know what can influence our heart rate. Exercise. What else? Huh? Exercise. Anything else that can change your heart rate?
Physical activity.
Physical activity. What else? Age, yes. You know, fetus, they beat like 100 to 160 per minute. Drugs as well. Sorry? Diet. So if you have a high salt intake, you have a more rapid heart rate. Yes. So, okay. I think you guys get the idea. So in terms of heart rate, we have chronotypes. So chrono means time. So like 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 when you say let's arrange something in chronological order, in time order. So chronotropic agents, chrono means time. So chronotropic agents are anything that can affect the heart rate, like how fast or how slow the heart is beating. And we have positive and negative chronotropes. So positive chronotropes are things that can increase your heart rate. So, if you increase the activation of your sympathetic nervous system by increasing norepinephrine, epinephrine, then this is going to increase your heart rate. Hormones like T3, T4, thyroid hormones, if you have more of this, it's going to increase that sympathetic nervous system activity again, which is going to increase your heart rate. If you increase your basal metabolic rate, so if you're exercising, if you have a fever, or if you have excess thyroid hormones in hyperthyroidism, then you're going to increase your heart rate. If you have hypercalcemia, that increase in calcium inside the myocardial cells, it's going to make it contract faster, so it's going to increase heart rate. We have drugs as well, like adrenergic agonists, catecholamines like epinephrine, norepinephrine, atropine, dopamine. All of these drugs can increase your heart rate. Stimulation of the peripheral chemoreceptors. So our peripheral chemoreceptors are located in the carotid and the aortic bodies. So they get triggered if there's low partial pressure of oxygen and high partial pressure of CO2. And what they do is they send like a message to the brain saying, look, we have low oxygen going around and we have high CO2 going around. So what the brain tells the heart is to pump faster, because basically what it's trying to do is, maybe if we pump blood faster, we're gonna clear out more CO2 and we're gonna deliver more oxygen to the cells. So the stimulation of the peripheral chemoreceptors actually creates this reflexive increase in heart rate. So whenever you have a situation where you're hypoxic or hypercapnic, increase in CO2, that's gonna trigger a reflex response of an increase in heart rate, because it's going to trigger those peripheral chemoreceptors. Okay, and the last one is anxiety. So I don't know if you've ever had like a major panic attack, but when you're having like just gently anxious or having like a panic attack, you can feel like your heart is going to come out of your chest, and you can feel like it's like a drum and it's so fast. So anxiety can increase heart rate. So the negative chronotropes now. So these are agents that decrease your heart rate. So stimulation of the parasympathetic nervous system, so by the release of acetylcholine, that's the opposite of the sympathetic nervous system. So this is going to decrease heart rate. Drugs like beta blockers and digoxin, and calcium channel blockers as well, they can decrease heart rate. And if you have strong and efficient myocardium, like marathon runners, endurance athletes, they have very efficient myocardium. So they have a physiological bradycardia. So they can have heart rates less than 60 and still be fine. So again, this can be explained by this very amazing equation. So how can endurance athletes afford to have low heart rate? They, like every single adult needs to maintain a cardiac output of 5 liters per minute. Because these endurance athletes, they have very strong, efficient, well-trained myocardium, the contractility of their heart is phenomenal. It's like amazing. Their heart is just so powerful. So the contractility of their heart is high. And high contractility means a high stroke volume. If you have a high stroke volume, that's going to increase cardiac output. So they can afford not to have such a high heart rate. So that's why they have physiological bradycardia. That's why athletes have really low heart rates, because they don't have to have such a high heart rate, because their stroke volume is already high from their very efficient myocardium. So I hope that makes sense. Do you guys want to go through some questions?